in 5, 4, 3, 2, 1. We are live now. Sir, you can start.
Good evening, friends. Greetings from Devbhoomi. It's an honorable evening for our association today to organize this webinar with Indian Foot and Ankle Society. Today we are organizing third webinar of State Orthodoxy series. This time we will enlighten our knowledge with renowned international faculty of IFAS from our own country. I would like to welcome Honorable President IFAS, Dr. Rajesh Simon, sir. Good evening, sir. Dr. KAMAL DUREJA, sir, from New Delhi. Dr. Pradeep Moonot, sir, from Mumbai. Dr. SM AJOY, sir, from Bangalore. So we are having esteemed faculty from our state, Dr. Puneet Gupta, President, Uttarakhand Association. Dr. Navneet Badoni, sir, Dr. Praveen Mittal, sir, Dr. Pradeep Meena, Dr. Pradeep Pande, Dr. Maneesh, Dr. Tarun Solanki. So I think we should proceed, sir. Now first, I will like to invite Dr. KAMAL DUREJA, sir. He will talk on management of malunion calcaneum. It's just not subtalar fusion. Dr. KAMAL, sir, please.
Thank you, Puneet. So I would first go on to share my screen, and I hope my screen is visible to everybody.
Yes, sir. Yes, sir. It's visible.
All right.
Yeah, fine.
So as the subject given to me is a malunited calcaneum, and I was thinking what to tell you about malunion of calcaneum, how to handle it. Most of us used to carry a concept that all malunion, because it is a subtalar arthritis, so we just need to do a subtalar fusion. But
sir, screens are not moving, sir. Slide is not moving. Now it's fine, sir.
Yeah. So all these malunion, are they the same? Different type of malunions you see, but is there a single solution to them? We will, as we go through this talk, we will understand that more. But first of all, why the patient with malunion comes to you? Well, he would have all these problems: pain, stiffness, fatigue, persistent swelling around the heel, gait disturbance, paresthesias and pains and neuritic pains, and toe deformities in the terms of clawing of toes. Any of these or multiple symptoms of these will happen in one patient. And we need to understand that we have to divide these patients into two different subsets. One, those who have pain often associated with deformity and stiffness, and a second subset, which primarily has, intermittent pains or neuritic pains or paresthesias, which could be either in the distribution of sural nerve or tibial nerve. So when it is paresthesia and neuritic pain, that means these nerves are getting impinged. There is an impingement from a displaced part of the calcaneum malunion. So we proceed with our physical examination, which starts with examining the heel from the back in a standing position and look at whether the heel is neutral, varus, or valgus. Invariably, the heel will be widened. Note if there is a surgical scar, previously they have been operated or not. Ask the patient to walk a bit and examine the gait, and you can see whether the toe push-off is present or not, heel is supinating while push-off is happening or not, or is it locked. Also, make the patient sit, examine the sinus tarsi. This will tell you whether the subtalar joint is arthritic or not. Examine the calcaneocuboid joint, look at the retrocalcaneal tenderness, look at the deformities of toes. Also check whether there is an equinus contracture. If it is present, do a silver Scott test. And at the end, must examine the range of motion which is present at the subtalar joint. So this physical examination finding should be noted, and it will help you to plan the management. And we have usually the X-rays which are done as a lateral view, which are done as an axial view. But the thing is, with this much of information which is available on the axial view and the lateral view, is it enough to start treating your patient? Well, sometimes I would say yes. And sometimes I would agree, no, it is not. So what is that sometimes? Because we need to understand that what kind of information do we need to plan? What information from the X-ray? We need an information about the presence of subtalar arthritis, of course, mixed with the clinical judgment. We need to have an information about the lateral wall exhaustosis, which will be appearing from an axial view, good axial view. We want to have an information about the reduction of height or the depression of posterior facet. Again, it is the standing lateral X-ray and not without standing, erect lateral X-ray, which will help us, and we have to compare with the normal contralateral side. If the other side is also having a calcaneum fracture, then of course this comparison is not possible. Then we have to look as to where the tuberosity is going. Is it lying neutral, varus, valgus? Again, your clinical judgment and axial view combined. So this much of information we can get from X-rays, but it has to be a good quality X-ray. Plus, you have to have a learning curve to understand how to read your X-rays and take out this information from the X-rays. So what next? Usually in assessment of a malunited calcaneum, the best part is if you can have an X-rays, which are from the time of injury, if you can have a CT scan, which is taken at the time of injury, and then you have a current CT scan, and then you can correlate everything. But more often than not, the X-ray at the time of injury is never present with the patient. He has lost it, or he has come to you after many, many years. CT scan, whether it was done or not done, is very variable. But yes, you will ask for a current CT scan. And how will that help you? Look at this X-ray, which is there on the leftmost side for the left, which is showing you a deformed calcaneum and obscured subtalar joint. But when you see the CT scan, you have to look at the pictures which tell you the displacement of different fragments in 3 different planes. Like the sagittal view here is telling you the depressed posterior facet, and coronal view in the broadest talus view is showing you the blown out part of the lateral wall of calcaneum, and this fragment, which is the lateral wall, is come to lie under the fibula. And the tuberosity in the axial view is clear cut, showing has got deformed into varus. So we have all this information very clear and quantified also as to how much things are bad, So this kind of information is available from CT scan. Another patient, 47-year-old female, 2 years after conservative treatment, that's the X-ray showing just subchondral sclerosis. But if you see the CT scan, it shows you a clear-cut osteophyte fibula, the lateral wall exhaustosis, the subchondral sclerosis, the reduced joint space, the varus heel, the broadened calcaneum. All this information is readily available to you. And you can see the posterior facet looking forward, looking anteriorly. The orientation is changed because it is depressed. It is an intra-articular posterior facet which has got depressed into the substance of calcaneum and united there only. Another patient, bilateral calcaneum, one treated by surgery, but the other side could not be treated. The one treated has a very good shape, lying neutral, and with all plates and screws showing very well reduced calcaneum, but the other side is deformed. And a CT scan of this patient is not only showing varus angulation. It is also showing translation. It is showing broadening. It is showing an impingement. So we have to now categorize how do we list the abnormality or what are the different problems in a malunited calcaneum. If we start analyzing problems, I would put them, you have to analyze 5 different problems. 5 different problems. So problem number 1 is the lateral exostosis. Look for it in the coronal views and understand that this could be responsible for your impingement of the peroneal tendons and sural nerves and responsible for paresthesia. So this needs to be dealt. Okay. Then second problem which you look for is the calcaneal height. The posterior facet, which will get depressed and flattened, will change the liver arm of calcaneum and produce secondary consequences on the talar inclination and even the ankle joint portion. As you see here, the talus has become literally horizontal while it has to form an inclination angle of about 18-20 degrees. And see the talar angle here, inclination angle has become 8 degrees. That is also called talar declination. Third problem, which you have to see in malunited calcaneum, is the altered orientation of the tuberosity of calcaneum. Either it's onto varus or valgus, because this will have a detrimental effect on the tarsal joint motion. So here are the examples of valgus orientation and varus orientation, which you got to understand when you are seeing analyzing your personality of malunion. And there is a subset, there is a different subset whereby the tuberosity is just getting translated laterally. It is, instead of lying under the tibia, it has come to lie lateral to the tibia. Almost the whole of the tuberosity or 60% of the tuberosity is lying under the fibula. And then most of the cases would have a subtalar posterior facet arthritis, but you also have to look at the calcaneocuboid joint, because the fracture lines which have displacement of the anterior facet of the calcaneum will also lead to calcaneocuboid joint arthritis due to the incongruity happening there. So this is how you list 5 different problems. Now, what a nice thing would it be that if we have a classification which take into account all these 5 problems one by one, and which also guides you that what would be the treatment. So classifications have been changing with time. Earlier, we used to follow Stephen and Sander classification, but now we follow Zwipp and Remmel classification for the reasons it has taken into considerations all the problems. It has also given us guidance or the principles of management according to the type of Remmel classification which is existing. So how are these? We start with type 0, where we see only lateral exostosis, but a good subtalar joint. I mean, the cartilage of the subtalar joint has not degenerated. There is just lateral exostosis, which may be giving pressure symptoms on the peroneal tendons or the sural nerve. So these kind of cases are the cases where you have to open them, mark your exostosis, and simply excise this, put some bone wax on it, and your patient becomes asymptomatic. So this is type 0. This is next coming to type 1. When in addition to lateral exostosis or independent of lateral exostosis, there is arthritis of subtalar joint. Mind you, just arthritis. There is no problem other than arthritis. There is no reduction of height. There is no change in the tuberosity orientation, just arthritis. So these are the patients which can undergo a in situ fusion. So in situ fusions and lateral exostectomy if the lateral exostosis is also present. So this is type 1. And you don't need to really work hard on these. You can do them through a sinus tarsi approach or through a lateral stem cell approach. And then is the next type. Next type is where all those things which were happening in type 0 and 1, in addition to that, there is a different kind of orientation of the tuberosity. Either it has gone into varus or valgus. So when this is present, you can't just manage these things with simple subtalar arthrodesis. This is the stage, this is the type from where you have to change your plan. You have to plan differently. And how you have to plan differently? You see this varus, that means you have to either put an asymmetric wedge bone graft at the posterior facet to correct this kind of orientation, or you have to do a proper Dwyer osteotomy to correct the varus of the heel. And then you have to do the additionally your subtalar fusion to handle your subtalar arthritis. Next comes the type 3. Well, type 3 will have an additional thing which you have to see. This is reduction of the calcaneal height. So reduction of calcaneal height due to depression of the posterior facet will more often than not be associated with some amount of talar declination as well. So if we don't correct this height and this talar declination, patient is always going to have suboptimal result. So what do we do in these kinds? So what are the principles of managing this? First thing is always assess how much is the height reduction. And that's possible only if you take standing x-rays of both the side and calculate the height from the floor to the dome of the talus. And that tells you how much height reduction has taken place. So that is the amount of graft, tricortical graft, which you need to put between this facet here so that this gets elevated. So here you see the height reduction, and how to manage this is you correct the varus angulation by a Dwyer osteotomy, fix your Dwyer osteotomy with one screw, proceed to put a tricortical graft at the posterior facet so that you achieve a normal height from here to the dome of the talus. And then you are passing your screws for the subtalar fusion. So that's how the final result comes, that the heel is lying in the center, orientation is normal now, and the height is also achieved. And next is type 4. Type 4 is a different subset, which is sometimes seen here. As I showed you earlier, the whole of the tuberosity is getting translated laterally. And this translation can be seen here mixed with an angulation. If it is mixed with an angulation and the injury is not too old, what you have to do in these cases is an intra-articular osteotomy and reduce this translation by doing almost a reduction, open reduction, holding it with wire, seeing to it that you have restored the medial border again. You have brought this tuberosity fragment and sustentaculum fragment into the right kind of orientation and fixed it before you proceed for subtalar fusion. So after fixing this with a screw, you proceed by putting again a tricortical graft here and then doing an arthrodesis. Now these type of arthrodesis, wherever we are putting a graft, they are called distraction subtalar arthrodesis because we are distracting the subtalar joint to achieve the height, and then we are arthrodesing them. So another principle which works better in these cases is to not pass parallel screws, rather divergent screws, because the divergent screws would not permit the collapse of the graft. Another thing which you can do is use one of the screw which has long threads. So long threads, when they engage into calcaneum as well as talus, also prevent the collapse of this graft. So these principles of using long threaded screws, divergent screws, along with a tricortical graft form the basis of doing your distraction arthrodesis. And you see the benefit of this. My 39 mm preoperative height has got increased to 48 mm when I used a 10 mm graft and just had 1 mm collapse by the end of fusion, which took place in 4 months. And the talar in declination, or the angle of talar inclination, which was 8 degree, increased to 18 degree, which would be helpful for a good ankle range of motion. However, this is a different game when you have these injuries coming to you after about 8 years, 9 years, or 6 years. So that was a case which came 6 months after the index injury. But a case like this, which came 9 years later, you don't find the plane where to do the osteotomy here. It's so well fused, so much ossification, so much new bone formation has taken place. So in these kind of cases, you plan an osteotomy, exosectomy, and you plan a medial calcaneal slide osteotomy, because the tuberosity has translated laterally, you translate it medially, and that's how you do it, and you achieve an alignment which is tuberosities come to lie under the tibia and no exostosis and a good subtalar distraction principles also maintained. Last is the type 5. Type 5 are those where, due to persistent reduction in height and varus tilt, the ankle arthritis also happens. And in these cases, you need to fuse your ankle joint. Or when there is an involvement of CC joint, you may have to do a pantalar kind of a fusion in these kind of cases. So goals of reconstruction of a malunited calcaneum in complex cases is where you reduce the calcaneal height to normal, you bring it back to normal, you change the talar declination, reduce it to bring it to a normal inclination, you reduce the translation of the tuberosity, you correct the orientation of the tuberosity, and of course, you deal the subtalar joint by doing a distraction arthrodesis. So it's a distraction arthrodesis plus a sagittal plane orientation, which you have to achieve at the end. So to summarize, we need to understand the pathoanatomy, list our problems, deal them step by step. And usually this first step is exosectomy, because the bone which you remove in the as an exostosis can also be used as a graft if it is good enough, or otherwise you have to take a tricortical graft from iliac crest. You change the orientation of the tuberosity. Either if it is minor, do just put a wedge graft. If it is more, do a wire. Achieve the height by calculating it preoperatively and using a tricortical graft, and then achieve an arthrodesis with the principle of distraction arthrodesis. That means using your divergent screws. Thank you. Thanks. I'm done.
Thank you, sir. Nicely precise the talk. Now over to Dr. Ganesh and panelists. If any questions?
Yes, sir.
Sir, Kamal sir, is there any specific indication to use headless screw or simple head screw or fully threaded or partially threaded screws?
I would say it's only a luxury. I get headless screws easily here. Otherwise, it's not essential. But yeah, one thing is good. If you're going to use a headed screw, please have a countersink with you to slightly 2 to 3 or 4 mm sinking of the head into the calcaneum. Then the patient doesn't feel the impingement or the foreign body sensation.
Sir,
Sorry.
Yeah, Dr. Pradeep.
So in patients with only subtalar arthritis and exostosis, you opt for sinus tarsi approach or lateral extensile approach?
If you are good at sinus tarsi approach, the only problem which can happen in sinus tarsi approach is you have to first separate your peroneal tendons. So your dissection along the lateral wall, you have to go slow and be very clear that you are not harming your peroneal tendon or sural nerve while you are lifting all the soft tissue from the lateral wall exostosis. But when you are raising a flap in the extensile, everything is visible. You know, the visibility of separating the wall and the peroneal tendon is very little in the sinus tarsi approach. So if you have done a couple of sinus tarsi approaches, then please do it through sinus tarsi approach. Otherwise, if you're a beginner, it's always good to do a lateral extensile approach.
Sir, what do you think about the primary arthrodesis in case of severely comminuted calcaneum fracture, where the primary reconstruction or a construction of the construct in those cases is very difficult? So what do you think about the primary arthrodesis in those cases of severely comminuted calcaneum fracture?
Well, the biggest complication of subtalar fusion is failure to achieve subtalar fusion.
Non-union.
Okay, non-union or so-called failure to achieve fusion. Now, why does that happen? That happens because the subchondral bone of the calcaneum has become sclerosed and poorly vascular. Now, this is the same situation when there is comminuted fracture. Your subchondral bone has lost its vascularity. So the chances of a non-union or a failure to achieve or a delayed fusion are very high. So it's not a good idea to do a primary fusion. Do whatever reduction you can. If you can reduce height, if you can reduce width, whatever elements of the primary fracture you can deal them, do them, and leave it and guide your patient that this is a bad fracture and you will need another surgery, which will be a fusion after some time. The chances of achieving fusion in the second time are higher and better compared to doing a primary fusion.
Sir, the screw you are using, you need a compression or you need a positional screws?
The first screw which you pass into the neck, you can use it as a compression screw because you want talus head to be pulled down so that talar inclination improves. Okay. But the second screw should be used only as a position screw.
So it should be fully fitted.
The posterior screw should always be only a position screw, not a compression screw, because compression screw will again reduce your height, which you have achieved.
If we are increasing the calcaneal height in depressed fracture, how often we need the Achilles lengthening, sir?
Very rarely we need the Achilles lengthening, but if the whole calcaneal tuberosity has rotated and it is rotated in such way that the posterior part is, instead of looking posterior, is looking posterior superior. In those cases, presume that there will always be an equinus contracture or Achilles tightening, and always start with a simple percutaneous tendo-Achilles lengthening in these kind of cases.
Sir, we as a surgeon are fearful of wound complications. And when we are dealing with calcaneum malunion, we think that it will require maybe wound complication apprehension is much.
You are better off than an acute condition of calcaneal fracture, because the skin has, overcome that initial trauma. You've been walking around, everything is good. So skin vascularity is at its best. So if you are raising a lateral extensile flap in an acute trauma condition, it has more chances of complication than in a case of malunion.
Thank you, Kamal sir. Now we should proceed for the next talk. Ganesh.
Yes, sir. I would like to request Dr. Manoj, sir, who is a well-known figure in IFAS community. Sir, you are welcome, sir.
Thank you so much. Thank you. I would like to thank the Uttaranchal Orthopaedic Association, IFAS, Dr. Puneet, Dr. Ganesh for inviting me for this talk. I'll be talking on approach to Lisfranc, acute Lisfranc injuries. Okay, you can see my slide.
Yeah.
Fantastic. So these are the objectives of today's talk. Now, just start with the one case. The first case is a 30-year-old female, minor fall from stairs and diagnosed with a midfoot sprain. And these were the X-rays which were taken. Was seen by a second physician, diagnosed as fracture of the base metatarsal, treated in a cast for 6 weeks. And she presented to me 3 months post-injury saying, "Doctor, my foot does not look normal. You see the right side is not normal. Left side there's a bump which has come in, and I think I'm getting some deformity of flat foot on the left side." And these were the X-rays as 3 months post-injury. And you can clearly see what is happening here. The second TMT joint, the Lisfranc joint, is not normal. There's increase in the chest space between the first space of the first and the C2. Okay, that's the increased space and the widening. So why missed Lisfrancs are important? Because if you miss a Lisfranc, they can cause a lifetime of issues with chronic pain, function loss, and deformities. And usually the deformities pes planus or the flat foot. I've seen patients with even a pes cavus as well. But most of the time it is a flat foot deformity which causes a problem. A bit of brief of anatomy. The Lisfranc, I like to divide this into 4 major units. The first unit is the first TMT, and unlike what people think, there is some movement. There's a 6 degrees of mobility present. The second and the third TMT joints are completely fixed with 0 mobility, and the lateral part, that's the fourth and the fifth TMT joints, are the mobile fragments or the mobile part of the whole unit. So 3 different types. A Lisfranc ligament, I'm sure everybody is aware, it's a large oblique ligament, goes from the plantar aspect of the medial cuneiform to the base of the second metatarsal. And it has 3 different parts, the dorsal, interosseous, and the plantar. And the most significant and the strong part is the interosseous part. The reason I've kept this slide is not to show you the anatomy, but I would advise and suggest every time you're thinking of, or next time when you see an MRI of the foot, look at the cross sections or the axial views and try to identify the Lisfranc ligament, because once you learn to see it normal, when you see an abnormal, there'll be a fluid in that, or if there is a tear, you can probably identify it, because many times the MSK guys may not see this or identify it or what you're suspecting. So learn to do that. Coming to the classification, the pure ligamentous injuries are classified in 3 types. The first type, where there is minimal swelling, no instability of the joint, even if you take weight-bearing X-rays, there is no disruption, there is no displacement as well. In grade 2, the pain and swelling is increased. There is mild instability or mild laxity, but no instability. So you will see maybe a mild displacement, but definitely less than 2 millimeter. The third type, which is the most significant type, where there is complete disruption of the Lisfranc ligament and there is instability. So there is a diastasis of more than 2 to 3 millimeters. That is what the problem of your ligamentous Lisfranc can cause. Physical examination, you need to have very high index of suspicion. In my books, any patient who comes with a midfoot swelling, midfoot pain, midfoot sprain, in my books, it is Lisfranc unless proven otherwise. So patients with polytrauma, look at the vascular status, assess the soft tissue, and especially we have a high velocity trauma injuries. So again, marked here, swelling and large lump in the midfoot, unable to weight bear, tenderness along the tarso-metatarsal joints, and tenderness even present on the passive midfoot pronation, supination. So hold the toes and just try to move a little bit, pronating, supinating, or rotational movement, and the patient complains of pain in the midfoot, it's Lisfranc. Now we do not do this, but always see on the plantar aspect of the foot. And if you see this ecchymosis, it's almost like a telltale sign of a Lisfranc joint. And as I said, hold the metatarsal heads, usually the second and third, and try to just move it up and down, what we call as a piano key side, And again, if they complain of pain, that's again key sign of Lisfranc injuries. Radiographs, AP, lateral and 30-degree oblique views are mandatory, and you need to learn to look at all the lines. Those are completely different things. I'm not just covering into this. It's just because that itself is like a 5 to 7 minute presentation. But the key thing is when you're looking at a weight bearing, also a subtle sign is called as a north sign, which donates a medial cuneiform rotation. Look at this X-ray where you can see there is a, on the left and the right side, the cuneiform is slightly rotated on the weight bearing X-ray. And again, donates may or may not be present with C1-M2 widening. So it suggests a mild intercuneiform instability. That's also important. Lateral views, now we are not looking at a very subtle Lisfranc. Again, you can see weight bearing, the slight dorsal subluxation also needs to be seen. Look at that. All these X-rays or the subtle signs, we are not looking for these type of injuries. What we are trying to see is patients who have this kind of X-ray, but a flake sign in here. How do we say that this is a stable or an unstable? Best is to get a weight bearing X-ray. The similar X-rays of this patient, now you can see how there is a step, and this is a pure Lisfranc injury. Additional imaging, if you need to do it, you can get a stress views of fluoroscopy, take them to theater and stress them, get a CT scan done, MRI scan them, or if you are very highly suspicious, and this is what I do, I wait for a week, let the swelling settle down, pain settle down, get them to my clinic, and then get a weight bearing X-rays and keep looking. So in terms of management, what is the management for these cases? Either conservative or surgical, and there's always a dilemma. The goals of treatment is usually to get a painless, plantigrade, stable foot. And the key is to maintain the anatomic alignment of the Lisfranc joint or the second TMT joint, because this is a critical factor in achieving a satisfactory result. If you're very sure that the instability or the displacement is less than 2 millimeter, then you can go ahead with a non-operative treatment. So 2 millimeter displacement is a critical thing. And there is no other instability present on weight bearing. And for non-operative management, I put them in a cast, a short leg non-weight bearing cast for 6 weeks. But you need to assess them for the first 2 weeks, serially weight bearing X-rays, and make sure that they are not displacing further. Operative results, best results are seen in patients who have anatomic reduction and stable fixation. And a lot of times people ask, when do you do the surgery? You can easily wait up to 2 weeks for the swelling to settle down, and then you are able to achieve a good reduction of the various joints which are involved. Now, before you take the patient, so after you've taken the patient for theater, and before your skin incision, always I try to do is screen the patient under CR and try to find out which TMT joints are unstable. Sometimes initially you would have thought only the second TMT is unstable, but when you stress them, you find that even the first may be unstable, or the first, second, third may be unstable. Now, if the the 3 medial TMT joints are unstable, then 2 incisions are taken. The first one is on the medial side, or a dorsomedial or medial incision. That is for the first TMT. And for the second and third, the incision is usually on the third, or between the second and third. So that's why it is critical to screen before you put your knife to the skin. Because once you open up, say, a second TMT, and then you find your first also needs to be fixed, and third, it is very difficult. It is possible, but difficult. And there's a lot of stretching involved. So I would advise just plan it before you take the skin incision. Now, if you're planning only first and second, then you can do your incision in the first web space. Okay, identify and protect the neurovascular bundle. Now, recently in the IFAS, somebody suggested in the WhatsApp group, how do you identify the neurovascular bundle? Usually in Lisfranc injuries, in the acute cases, there is so much of edema, there is so much of dissection already done that as soon as you put your skin knife and you wash out the hematoma, the whole soft tissue bundle is already taken away and you are straight away into the joint. But be careful to do a blunt dissection and expose the TMT joint. So here, as soon as I've taken my skin incision, and you see how you can identify that's my periosteum elevator into the first web space, or between the first and the second metatarsal, and you can see the instability. Now reduce the second Lisfranc joint with a clamp and then pass a guide wire from the base of the second metatarsal onto the medial cuneiform. And the key thing is two things here you need to do. You need to make sure that your neurovascular bundle or your Lisfranc joint is anatomically reduced and a direct inspection as well as on the x-rays. Both needs to be sure that you have reduced it. Once that's reduced it, then you can check if your first TMT also is reduced or not, or you can go and reduce your first TMT joint. Along with it, the lateral TMT joints are displaced or not, you can check that. And if you want to take a lateral incision, you can do that also and reduce the third and fourth or fourth and fifth. Now, once your reductions are achieved, now you want to go with a permanent fixation. The first is a Lisfranc screw, which goes from the base of the second to the medial cuneiform. Now, if you look in the older textbooks, most of the time the screw goes from the medial cuneiform into the metatarsal. Yes, you could do that, but it's always easy to aim from a smaller bone into a bigger bone. It's the other way around. So you find that this way it is much better. Also, if you see, this is a fully threaded screw and not a partially threaded screw. You don't need compression. Your reduction is already achieved by your pointed clamp. So this is a positional screw. So it is fully threaded 4 mm. Usually it should be a non-cannulated screw, but it's difficult sometimes. I many times use a cannulated screw. I have not had a problem. Also check for intercuneiform instability. If that is the case, put an intercuneiform screw which goes from the medial cuneiform into the intermediate cuneiform. Now, second, TMD joint. Once that is done, I always try to neutralize my Lisfranc joint with a neutralizing plate. Medial column, if needs to be fixed separately, I fix with a plate. I do not use now transarticular screws, and I'll tell you why. And along with that, if the fourth and the fifth joints needs to be unstable, those are now fixed with a K-wire, either 1 or 2 K-wires. Now, this is a nice paper which has come out recently, which talks about dorsal bridge plating or transarticular screws for Lisfranc fracture dislocation. And they had 108 patients, which 38 went through transarticular screws, 45 by dorsal bridge plate, and 25 by a combination. And they found that the better functional group were people with the bridge plate. Functional outcomes were dependent on the quality of reduction. That's what I say, get your anatomical reduction. And greater the number of columns, the worse the outcome. That is quite understandable, logical. That means the greater the column, because that is the severity is quite high. That means the outcomes will be affected. So patients with dorsal bridge plating had a better functional and radiological results than a combination technique as well. And these are here just few cases how different ways have been fixed. Again, plate, a dorsal bridge plate and a medial bridge plate and a Lisfranc screw. Okay, so coming to the last point, pure ligamentous injury, and this has always been a debate. Do you do an open reduction internal fixation, do a primary arthrodesis, or something else? Now, this is a new latest paper from 2019, flexible fixation technique for Lisfranc injury, and they have used something called as initially used to use a mini tightrope, but they are using now internal brace, and it may present a superior option which replicates a normal anatomy and also does not require removal of implants. So here you can see on the left, there's a subtle Lisfranc which has been reduced, and also intercuneiform has also been fixed by an internal brace. So this is just one of my cases which recently done 2 months back. After the intercuneiform also, there is a Lisfranc instability is still there. And this is the mini tightrope which I have used. And if you can see here, after the fixation, the Lisfranc has been stabilized. It will just show you in the end how nicely you can see the line here clearly. There's no gaping present as well. So you can use these type of fixation as well. So just few cases in the last. So 34-year-old female involved in the road traffic accident, and you see the severity of the injury. Now understand this, there is a significant Lisfranc, but at the same time, the base of the first metatarsal is also fractured. That's the kind of swelling he had with ecchymosis, or she had with ecchymosis. And look at the CT scan, completely all the joints are out. And most of the time with these kind of complex injury, I get a CT scan done as well and go through the whole thing myself as well. And you see, that's your base of the first metatarsal, which is fractured, and there's a large piece. So that needs to be fixed as well. So 2 incisions were planned. One is complete medial because I wanted to access the base of the first on the medial side and fix it. So that is where I fixed with first an interfrac screw and then a long plate spanning the first TMT joint. That is what was done. So the first ray is now stable. Now coming back on the medial side, that's your Lisfranc reduced with a clamp, Lisfranc screw being put in. So I now know I've got an anatomical reduction of my Lisfranc, and then put an X plate on the second and third, and the lateral sides I have put in KYs as well. And that's the results. He was actually just with me around half an hour back. He's doing quite well. So that's your final outcome with nice arch being maintained. All the wounds have healed quite well. So these are another few cases with a mild Lisfranc. So you see 2 months later, this chap has come, or this lady has come with mild pain and swelling, and a weight-bearing X-rays. You can see there is a slight subluxation with a slight gaping present with like a flake sign. Weight-bearing CT scan showed a deviation. That's a reduction. Hairline, that's an anatomical reduction fixed with Lisfranc screw and a plate. Another patient, again with Lisfranc screw and once neutralizing plate. This is a patient, I think, with a weight-bearing CT scan showed the first TMT joint instability. You can see the patient came with pain over the first TMT joint. He did not have pain on the Lisfranc joint, but the first TMT joint was painful. And that is where you can see the first TMT and the second TMT also was unstable. There we can clearly see, you put a screw and see how that unstable, intercuneiform as well as a Lisfranc joint, unstable. So that was reduced. That's a artery foci showing the displacement or the mild reduction of the first TMT joint, reduced with a Lisfranc screw and a TMT plate. And that's the final outcome. Post-operatively, they go in a sprint for 2 weeks time. Non-weight bearing is almost for 6 weeks. And then with an arch support, they walk for almost 6 months. Usually hardware removal, if their joints spanning, needs to be removed between 4 to 6 months time. And KYs can come out in 6 weeks time. Usually, if you have anatomical reduction, your outcomes are more than 90% in patients, compared to only 1/3 of the patients who have non-anatomical reduction. So in conclusion, these are commonly missed injuries. There's nothing like a midfoot sprain. I treat Lisfranc injury unless proven otherwise. Anatomical reduction is the key. Nearly all of them, if you see a displacement, needs open reduction and internal fixation, except if they have open injuries, so need to be treated differently. Again, words from Lisfranc: surgery is bright when operating, but it is still brighter when there is no blood and mutilation leads to patient's recovery. Thank you very much.
Thank you, sir. Any question from the panelists? Any?
Pradeep sir, what is the right way to take weight-bearing X-ray?
So the key thing is you need to make sure your X-ray machine really goes down to the floor. Now the problem in all our clinics, and not hospitals, but usually clinics, is the machine are usually half portable or 100 mA3 and they do not go really down. So you need to have a special footstool made where you can keep your cassette at the bottom and keep it at the vertical. If you see on the internet, you will find a lot of different models with it. So in my clinic, I have made special stools, or 2-step stool, where you can put your films underneath your wooden partition and a slot vertical, you get your X-rays. But these are very, very important things. It means for Lisfranc and for flat foot, 2 things where without weight-bearing X-rays, planning is just not possible.
Sir, what is the need for primary arthrodesis? Do you consider the need for primary arthrodesis in few cases, or some cases where there is articular involvement, crushing of the articular surfaces?
So what I do is I counsel my patients, if in the preoperative X-rays that the joint is quite damaged, then I would counsel them. But if the end result is on table, if I find that the joint surface looks good, then I would try to salvage it. But also there's another talk of mine on best Lisfranc. By 3 to 4 months time, if the joint is completely out, then you know that that cartilage is not going to be healthy. So in those cases, like a delayed presentation, then I would counsel more for a joint fusion or an arthrodesis. But coming to the pure ligamentous, always the debate has been pure ligamentous, do you do a fusion or not? I think with the flexible fixation, I think fusion, I do not see a problem of doing a flexible fixation versus a fusion.
Thank you, sir.
Sir,
That you
sir,
remove
are
these
you
implants.
use medial arch support in these cases?
Yes, I give them customized insoles almost for a year for these patients.
So when to remove these implants?
Sorry?
When to remove implant?
At least not before 6 months, because that is the time which for the ligaments of the Lisfranc and the first TMD joints it takes for complete healing. So I would not remove them before that.
Okay, thank you.
So during the surgery, at what moment do you decide that the Lisfranc screw is not enough and you need to add additional plates?
So if you see, like if you have a very subtle Lisfranc, then maybe a one screw may be enough. But my point is, I always, if you're there, I always try to put a 2-hole plate. That's a small 2.4 or 2.7 mm. I know that then my screw is not taking the full load and I do not need to be putting them in a plaster. So my fixation is quite good. I just put a splint for 2 weeks. I mobilize them, but I make them weight bear at 2 months.
So you combine both the screw and the plates together as
always, most of the time, yes. But
okay.
These are transarticular plates. They are not, sorry, they are joint spanning plates. They are not transarticular screws. Because we know the fact that every time you pass a screw across the joint, 33% of the joint surface is damaged. So if you're, that's why they showed it in the first TMT. If you put 2 screws, almost 60 to 70% joint is damaged, and these people will have arthritis.
Okay.
Thank you.
Thank you. Thank you. Sir, coming to the next speaker is Simon sir is there.
Rajesh sir.
Rajesh sir.
Thank you guys. Thank you, Uttarakhand Orthopaedic Association for having got Indian Foot and Ankle Society into this picture and getting spreading the knowledge of foot amongst all of us. It's always learning for all of us, and I am sharing my screen. Is it visible?
Yes, sir. It's visible.
Yeah. So my talk on today is on Charcot catastrophe, early diagnosis to salvage. Now, I happen to be the president of this year's Indian Foot and Ankle Society, and this is a theme of mine as a president of Charcot catastrophe, Save the Foot. Something which we orthopedic surgeons do not learn in our postgraduate days. We are trying to change that because as per the present, the way it is going, we are becoming the diabetic capital of the world. And possibly by 2025, we will be having the most amount of diabetic patients in our country. So we are looking at a huge amount of diabetic patients. We all know this, or most of the senior people know about this two guys, the Laurel and Hardy. I compare our diabetic patients with this. The diabetic patients could be having an avascular because of the vasculitis, or a hypervascular, which is again because of hypervasculitis. And that is where my patients come in this particular topic, the Charcot foot topic, the hypervascular, most of them. Yes, we have a minuscule patient who are a hypovascular also. And this added on with a neuropathy is the criminal for all this problem. So as I said, by 2025, we're going to have the biggest diabetic population, and 5 to 9% of them convert to Charcot foot. And if you're looking at 5 to 9%, when it comes to numbers, we are looking at a population more than countries like Denmark having Charcot foot alone. And if we as orthopedic surgeons do not diagnose it and treat it properly, then a huge amount of population is going to suffer. And amputation here is not an answer. So when you look at a swelling around the foot, next time onwards, think differently. Don't send it to your general surgeon or a physician saying that this is cellulitis. Look at the HbA1c, look at the patient, look at the swelling around the foot. It might not be painful. It would be just a red swelling, swelling of the foot and ankle region. And it might be the beginning of the Charcot foot disease. And if you take an X-ray, you'll be surprised to see that there is already a fracture formation there. So Charcot foot if you look at the diagnosis, is a relatively painless, progressive, degenerative arthropathy of single or more joint, usually more joint, and causing and with an underlying neurological deficit. So you see this patient with a red hot leg, but the patient is relatively painless. They are walking pain-free. That is where you have to suspect this might not be cellulitis. It can be a Charcot neuroarthropathy. Clinical presentation could be because of a minor trauma, mild to severe swelling. Warmth is always there. It is always warm. That is why we think about cellulitis. Early patient might have some amount of pain, especially when you ask them, when your leading question is, do you have pain when you're pressing? They'll say yes. But when they are talking something and then you press, there might not be pain. Vascular compromise usually is not seen in the Charcot foot because, as I said, it's a hypervascular. But then, yes, there is a fraction of patients who are hypovascular also. And the most important catchy thing is discomfort is considerably less. That might be expected when you see the feet. And always, many of us, we manage this as cellulitis. So this is something which we have to understand. Managing between these two tummies. You cannot change these two tummies in the same way. You cannot treat it. You have to look at it completely different because these are completely different entities, a cellulitis versus the Charcot foot. So acute Charcot diagnosis, you have to understand that investigations are not helpful. Investigations are not really useful in the early stages. MRI scans and bone scans does pick up the problems, but you cannot differentiate between the infections, osteomyelitis, or a Charcot foot. But HbA1c is one of the things that can lead to the suspicion of the Charcot foot. So this is one of my own patient in my early days when I said this is Charcot foot. Now look at this, why I thought about Charcot foot was, why is it important to diagnose at this stage is because when I saw this foot, I saw this swelling and then the X-ray, this was something which caught my attention. A small spicule of bone. I hope you guys can see it. A small spicule of bone there. And I said, this is Charcot foot. The patient went back to the physician and he said, no, your X-rays are fine. It is okay. It is just cellulitis and antibiotics was given. 2 years down the line, the patient comes to me like this. Now that small spicule has become bigger. And now you can see a complete catastrophe of the midfoot. The foot has completely become rock bottom. This could have been saved by just putting a plaster initially, but we missed the boat because the physician did not identify it early. So if you look at the classification, the Eichenholz classification says the stage 0 is the best time to treat, identify, though it is difficult to identify, but a high degree of suspicion is what is going to help us out. There might be no significant cell count increase, and the X-rays might be normal. It is just the high level of suspicion that helps you out in diagnosis. And if you can take a bone scan, and if there says an uptake is high, then yes, think about Charcot arthropathy. Look at this, how the bone changes. If you look at this video, This is how it is. This is how the bone collapses. And what happens is this osteoclastic effect is so much activated just because you're moving. In diabetic patients, most of us say that you walk. Make sure that you walk so that your sugars are down. Keep on moving your fingers so that your circulation is better. But in Charcot neuroarthropathy, every time you move, your osteoclastic activity is increasing and the foot, the bones completely start disintegrating. So that is why we go on with something called a total contact cast. We don't have yet any good medicine. There are people who have done on different usage of bisphosphonates, or now we have one denosumab, but there is no definitive treatment for it. The treatment in acute phase is total contact cast, and here you even immobilize the toes. There is no movement even for the toes, so that the osteoclastic effect is minimized and the patient, the fragmentation, from the stage of fragmentation, the consolidation phase comes in. So this is something which we have to treat. This is the place where you can treat the best. Once the consolidation is over, then you can give them something called as the crow or the Charcot wrist-trading orthotic walker, a customized walker where patient can walk with the boat in the initial phase, and then you can lead on to the normal customized footwear. But unfortunately in India, this is where our treatment starts, and this is where I would like to say this is salvage. You can salvage. And these are the few cases which are of my own patients. These are not internet pictures. These are my own patients whom we have come across, and this is how they're presented because they were not picked up in early stage. Let's start for a few of these cases. This is one lady who came with me with about 3 years of non-healing ulcer, and you can see the callosities that has increased. And she was advised amputation when she came to me because this wound just wouldn't heal, and she was really annoyed about it. Now, this was the X-ray, and you can see why the cause of it. The whole cuboid is underneath there, and that was leading to the non-healing ulcer. It was the rocker bottom feet because of the collapsed cuboid. And I just did an exostomy of the wound, and the wound healed, and then did a reconstruction. And look at 1 year's time, you can see the difference, the complete change in the foot shape and the foot ulcer. The ulcer is completely disappeared. The wound is completely healed. So it is not about the wound management. It is not because the wound is not healing. It is because you mismanaged it without treating the cause. We are treating the symptom of ulcer, not the cause. Another case, this is what I showed, the patient who came to me after 2 years with a rocker bottom feet with an ulcer, again, not healing. And again, you look at it, that is the cause of the non-healing ulcer. The cuboid had completely gone, subluxated down. And we did something, what we do as something called as the superconstruct. So reconstructive surgery, we normally use 2.7. We just heard Pradeep's beautiful cases, 2.7 plates, 2.4 plates. But in Charcot, 2.7 may not work. You might have to put much more thicker plates. And this you can see I put 3.5 plates and one plantar plate. You can use beam screws. Nowadays I've turned on to beam screws with the plates combination to do the reconstruction. You can see the whole limb is completely changed. We think 3.5 plates in that feet. You can see the difference. The foot is now much more better and no ulcer at 1 year's time. This was another case who had a fracture of ankle, but was treated with plaster and it converted it to Charcot. You can see how grossly unstable the ankle is. And you see this, we just had to do a ankle stabilization with a TTC nail and see how beautifully she walks without any problem. Now, you got to understand what is the problem. Look at this particular patient. she had a completely dissolved ankle. And if you look at her foot, the foot is also completely, midfoot is completely gone. The talus has completely disappeared. The cuboid is almost near total gone. Cuneiforms are partly there. So the whole hind foot and the midfoot is affected. The patient, you can see how she was standing. And this is what we did. We did a complete stabilization of the hind foot and the midfoot. And you can see the difference, how she was walking before and how she's walking now. You can, so the reconstruction is possible. You got to understand reconstruct different way. It's not a typical orthopedic fracture. It's a different thing. You have to undergo super construct, but it needs multidisciplinary approach. So when you look at patients with gross diabetes, here was a patient, 46-year-old patient, a huge patient with gross diabetic, gross infection. We got our endocrinologist, our nephrologist, everybody in picture, got the medical part confirmed. And you can see here, when we took an X-ray, there was no talus. The distal tibia and fibula were gone. The complete disarray of tarsals. When we took him for debridement, the tarsals were coming out like pieces, and you can see the pus oozing out. But we debrided, went ahead, debrided the whole thing, put an antibiotic rod, 3 weeks on IV antibiotics, vacuum dressings, and the wound started to heal. And then we did this hind foot fusion. And since there was a so active in this thing, so I stopped at hind foot. I said, okay, midfoot maybe in the next time. This guy is from Oman, and he went back. This was before the Corona times. And then he sends me pictures from his hometown. He never came back for midfoot reconstruction. And see, a person who did not have talus, who did not have distal tibia, who did not have distal fibula, now walking like this. Yes, I have insisted on him to walk, use a crow, but then this is how he walks so comfortably. Infections does happen, disaster does happen. This is my own patient whom I fixed like a Lisfranc plate 2.7, and this is how it turns out. If you do not go through the way super construct happens, then this can happen. If you go to a super construct way with proper implants, proper way, multidisciplinary, then yes, you can save the foot. So there are relative contraindications when your HbA1c is very high, the ABI index is not good, skin conditions are not good, patient is smoking, then it is a relative contraindication. But with multidisciplinary approach, you can save the feet. And this is what you have to understand, that you have to understand the fusion is to be extended beyond the zone of injury. Bone resection, you don't add on to the bone by putting bone graft and trying to lengthen the feet. You can shorten it, reduce the soft tissue tension, and use the strongest device available to get more stability. And that is what the super construct concept is for Charcot. And this is how you can save the foot. Why amputation? Why we did not go for an amputation? When we as orthopedic surgeons say, oh, it is totally mangled, why do you want to save the foot? Because there is a major reason here. Amputation is not good in a neuropathic foot because the function of these patients are not good after amputation. And many a times they go for the second limb amputation in about 5 years. The mortality rate is as high up to 56%. This mortality means it is much more higher than for a cancer patient. So if you are amputating, your 50% of the patient will not be living after 5 years. So that is the reason why Charcot feet should not be amputated and it should be salvaged. You saw my few cases, we have salvaged most of us, we have never amputated, but then it deserves a better attention and treatment. Multidisciplinary management is important. Prevention of deformities by just putting a plaster cast is in early stage way is helpful. Bony causes are the reason of the non-healing ulcers, and just by looking at the cause of that ulcer, you can treat everything. Surgical intervention at right time would give your patient a plantigrade foot, and most importantly, a better quality of life. Thank you guys for a patient hearing.
Thank you, sir.
Thank you. Thank you.
Sir, most of the time in most of the city, we are not getting a proper orthotist to make any foot support or any modified shoes. So what is your suggestion for a general orthopedic surgeon to intervene in this thing?
So early stages, you don't need orthotist. You just need you need to put a proper total contact cast. Only thing is the early diagnosis. So what happens is when you see these patients in the early stages, we treat them as cellulitis or osteomyelitis and send it to small ulcer, send it to a surgeon. I think we have to unlearn few things. We have to diagnose this. We have to just if you have a doubt, get a bone scan. I'm sure most of the places can get a bone scan or an MRI scan. And if there is an increased doubt about Charcot foot, just give them a plaster. Now the thing is, we have to educate the patient that this plaster is not for 10 days, 20 days, 25 days, 1 month. You have to educate. That is where our importance is, to educate the patient that this will take at least 2 to 3 months of plaster. So you have to keep on changing the plaster. You have to look at, because the patient's foot is insensate. He will develop ulcers if he starts walking on it. So you have to educate the patient. You have to say that this is going to be non-weight bearing. You have to keep on changing the plaster, look at the temperature difference. Once the temperature is normal, then that might take 3 to 4 months time. So 3 to 4 months of non-weight bearing, and then you don't need an orthotist. Orthotists are for those patients who are left for leprosy and polio. We have a stable foot once consolidation has happened. You just need a proper footwear. And that is where the Charcot foot management is. You don't really need a crow, that is the Charcot training orthotic walkers. And even if you have, I'm sure now like Uttarakhand is connected to Delhi. Delhi has got good. So this is not an emergency that you need to have it right now. You can send the patients for a crow if they need it. But the first is total contact cast.
Sir, suppose we are having an infected Charcot foot, then there is any role of applying gess or external fixator for ligamentous for the meantime when the wound
need external fixator.
Okay.
So this is where we have to unlearn, because the moment you put a pin there, that bone is, and you know what we need, why do we put external fixator in a compound fracture? Is because we want to inspect the wound, you want the patient to move the toes, isn't it? So this is where we have to unlearn from being an orthopedic surgeon. You have to think differently in this. You don't want the movement at all. Even the toe movements which we normally we do, we always operate and say move your toes, isn't it? But this is not here. We don't want even the movement of the toes, because every movement leads to osteoclastic activity. So that is where this total contact cast, even the toes are almost covered. Or in Western countries, they cover the whole feet. But in India, because of our hot thing, hot environment, I leave the toes slightly open so that, just the tip of the toes, but the toes are covered, that you don't see the toenails, it is still here, so that you don't allow the movements. So you don't need external fixator, one, because you're not looking for any movement, one. Second, if you have an ulcer, then put on a total contact cast, make a window, because you don't want movements. Now, if you put pins on those bones which are on the fragmenting way, you will fragment it further. So you
Sir, what
end
is-
up having a bigger hole than what it was before.
And what is the time for going for the
Ilizarov, yes, is
super
helpful,
construct?
but not an external fixator.
Okay, and what is the time for going for super construct after infected wound? Suppose we done all the wound management techniques, evac and everything, and now the wound healed. Then we have to wait for what time?
So the wound management is basically most of the time, like we have a malunited calcaneum, you do an exostomy, wherein the bone, which is the cause of your infection. For example, the one which I showed, the first case, the cuboid had come down and got infected. You just do an exostomy and do the wound management, close the wound. So staged protocol, and then you do the reconstruct after the infection is controlled. After the most of the time you do a stage this thing during the stage of consolidation. But then now we have Professor Venu from UK who says that even at the unstable stage, in the stage of fragmentation, you can do. I usually wait for stage of consolidation, but if there is an infection, active infection, I think I go and do an exostomy initially, do the wound management, or do the medical management, look for the vascularity. Most of the time it is hypervascular, but at times you have avascularity, then you have to get the vascular person also together. And then once everything is better, then you go for the super construct. Dr. Kamal sir, you want to say something?
So one concept is your Charcot arthropathy of the foot. And the other concept is Charcot arthropathy of the ankle, where ankle is disrupted.
The hind foot.
The hind foot, where the talus is, got fragmented. So in those kind of cases, do you think the total contact cast is still the answer, which is below knee? We have, from our understanding of an ankle fracture, being managed by an above knee cast. All right. So how do the concepts change when we have the disruption at the ankle? Can you enlighten us on that?
So midfoot is the most common part of the Charcot foot. So total contact cast is very helpful in midfoot stage.
Yes.
Hind foot, when the talus is almost gone or dislocating or ankle is unstable, this is the time where you can do it in early stages. So basically stabilization of the hind foot is very important, and you don't have to wait for the stage of consolidation to happen in hind foot. So in hind foot, even if it is unstable or there is an ulcer which is ready to form, so these are the two indications wherein you go, don't wait for the stage of consolidation to come. You can do an early super construct with your fixation.
What is the recommendation for ankle instability happening from Charcot with the presence of an ulcer which is communicating with the inside ankle joint? What is the recommendation for
so
that?
Always the recommendation for any particular infection is staged protocol. You get the infection in control, and then you go for a super reconstruct. But now when it comes to ankle, if it is unstable and infected, this is what I did. I showed you one of the cases wherein I put the tense nail with antibiotic coating, and I stabilized the ankle. So I took care of the infection with the antibiotic rod, and at the same time gave it some stability, because infection cannot be managed without stability. So you have to give stability to a certain extent. So that is how I managed with an antibiotic rod acting as a TTC and taking care of the stability as well as the infection.
Is there a role of Ilizarov frame?
Yes, Ilizarov is always there, always. I told you in between, external fixator doesn't have a role, but Ilizarov does have a role when it comes to infection also.
Sir, is there any role of NCV in these cases? Because most of the time patient is having diabetic peripheral neuropathy, the paresthesia is there. So how often it is safe to operate this patient when there is a paresthesia or altered sensation?
So basically, Charcot neuroarthropathy means the peripheral neuropathy, it is at its peak. Okay, there is already the destruction of the peripheral nerves has already happened. All this destruction is happening and patient is happily walking without sensation. So the peripheral neuropathy is anywhere there. So it is definitely, it is not arthropathy, it is a neuroarthropathy. So that has already happened. So that is where I said you are sitting with the patient and explaining, teaching them that putting a plaster, that does not mean that you can walk because you don't have pain. You have to make sure that you don't have pain, but you cannot walk, you cannot wait till the consolidation happens. So educating the patient is very, very important in a Charcot neuroarthropathy. Pradeep.
One comment just I would like to say, I think Rajesh, fantastic series, but I think people who are dealing with Charcot have to understand there will be a percentage of people even after fixation which will get infected. And I think, yes, you showed one case where you managed with a tense nail, but I think that is probably not, I would not say you're lucky that you got away with it, I would say. I think invariably once you have an infection, I think you need either yourself or somebody who can do a good eraser work has to be there to stabilize. Because once you have a very unstable foot or an ankle which is infected, till you do not stabilize it, the infection will not go. Because as soon as there is significant mobility, there is always going to be something called as a synovial fluid or a Charcot fluid, which will keep oozing up. So till you do not stabilize it, the sinus or the wound will not heal up. I think having friends or somebody who can do a good eraser work is always should be kept in handy to deal with such complex cases. Otherwise, fantastic presentation, Rajesh.
Agreed with you. I mean, I have been telling Ilazarov is one where we can always stabilize in an unstable ankle. This case, I did not put Ilazarov is because the patient was taken, but this guy was an Omani patient. He just wouldn't, he was a huge guy, 130 kgs, and he would not accept the Ilazarov. Yeah. We talked about him, tried to convince, and this is where I got away. Yes, not an ideal way, but this is how I got away.
One more comment, if I may, please. Puneet, is that okay? Can I, Dr.
Yeah, sure.
Yeah. See, one more thing is there, and I've seen it more and more often where people with significant hindfoot Charcot, but with a little bit of mild midfoot Charcot. But I do not think that the whole hindfoot and midfoot needs to be stabilized together. Okay, it is a big surgery. It makes your foot and your hindfoot and a midfoot very rigid, and chances of non-union and results going awkward are very high. And I think Dr. Rajesh showed in his case where he just stabilized the hindfoot and he left the midfoot because he wanted to come back 3 months. But you see that patient, the hindfoot stabilized because there was a little bit of mobility in the midfoot that allowed your hindfoot to stabilize and fuse it. So in mild to moderate, even midfoot you have, do not do a whole, I do not do it. And we have already submitted this. We have a case, 15 cases of hindfoot and midfoot, where only hindfoot has been stabilized, midfoot has been left by itself, and we have 5-year results showing fantastic outcome. So you do not need complete pan-talar fusion for these cases, because I think failure rates are more higher, which even Dr. Venu has shown, 30% failure rates if you do both together. Instead, if you want, you can come back and do it later. Just a comment.
Sir, in patients with Charcot ankle, where talus is totally destroyed, what is your experience with allografts, the solid allografts?
I already have a paper on that with an absent talus or a significant loss of talus in Journal of Foot and Ankle Surgery. I use the fibula. I take the whole length of the fibula, almost like a 3 to 4 inches. I make them into multiple studs and put it where the talus was absent. That is one way of doing it, and fill it with an allograft. That is one way. Second way, you can ignore it completely and get the whole calcaneum straight away onto the tibia. That's the second way. Third way, with the new 3D printing, you can do titanium cages. You can get a customized 3D printing titanium cages with a hole in the center for the TTC nail as well. So multiple ways to skin the cat.
Thank you, sir.
I just like to add one thing here. You have to understand you are dealing with a very highly osteoclastic activity. So expecting an allograft to be taken up is a bit too much. So wherever possible, avoid grafts. Whatever live bones you have, just fuse them into a sound ankylosis or a sound fibrous ankylosis. That should be the aim. A stability achieved, not a sound ankylosis. So the lesser you do in terms of bone grafts, the better it is in these kind of situations.
But if I just can say that allografts, I do have some experience with. Allografts do work well even in these cases. We could replace.
Guys, there's a huge rain coming in. That's why I can't hear. You're asking me?
No, I was just telling that
the role of allografts. Do we have a last word or some word from the literature? Rajesh, can you enlighten us? The role of allografts or autografts in dealing with Charcot arthropathy. Let's have one last word from Rajesh.
Rajesh, are you there? Rajesh?
Yeah.
Can you hear us?
No, I think there is some problem in that connection.
Okay, just put it on the chat and he will answer. Okay, Puneet, please put it on the chat.
Yes, sir. So we should proceed
And
for
let's
the next.
move to the next. Let's move to the next talk and put it on the chat.
Ganesh?
Yes, sir. Sir, Ajoy, sir. And then the next talk.
Yeah, hello. Yeah, can you see my screen?
Yes, sir.
Yeah, can you hear me also?
Yes, sir. Fine, sir.
Yeah, okay, fine. So with regard to the adult flat foot, so this is something which we have always been thinking about, and many thanks to the Uttaranchal Orthopaedic Society for including me and asking me to speak about the adult flat foot. These are the outcomes that we are looking at. We are trying to identify what are the structures which generally fail in an adult flat foot. We just try to recognize the stages of an adult flat foot, understand the clinical radical outcome for workup for this, and try to formulate a treatment plan based on the different stages that we are seeing these patients at. Now, the main thing that we consider, how different is this from a child or a flat foot in a child? In children, generally, it is a rigid flat foot that we are dealing with, and it can be secondary to coalitions, or it can be sometimes secondary only to a hyperlaxity. Whereas in the adults, the most common cause for all these flat feet is the tibialis posterior tendon. That's the one which leads to the forming of the tendonitis. Then this leads to midfoot, or the other things that we can think of is midfoot arthritis or midfoot fracture, malunion, calcaneus, cuboid malunions, and anything peroneal spasm in neuromuscular diseases, neuropathic deformities, and sometimes even coronal plane deformities can also cause this kind of a flat foot in the adults. But most often, so what we are going to deal with now here is the posterior tibial tendon and the associated things on the medial side, which are the ones leading to the adult flat foot deformity. And the current terminology for which is the progressive collapsing foot deformity. Now, there's classifications. So if we need to know something, we need to know how to classify it. This is one of the earliest classifications which had come. It had come from Johnson and Strom, and way back in 1989, and they had given only 3 stages. One, they said that the tibialis posterior tendon is just swollen and there is some tenosynovitis. In a stage 2, there is some loss of function and an absent single raise. And in a third stage, there is loss of this function with the fixed hind foot. So these were the stages which Johnson had given, Johnson and Strom had given, to which Blumen had added 2 into a 2A and a 2B. And later on, Myerson gave in the stage 4, which also involved the, in addition to all of these, involvement of the ankle also. And then further, it was classified into A and B. And in this A, where the hind foot was flexible, and B, where it was a rigid hind foot. So that's how we had gone through all of these classifications. And we do have used this as a guideline for treatment. Now, clinically, what are the things that we are looking at? We're looking at pain on the medial side of the foot. This is one of the most common things the patient comes to us with. There can be swelling. So if you can see all these patients, they have this classical swelling where it is just on the medial side, just in the region or the vicinity of the tibialis posterior. And the flat foot, of course, is obvious, the deformity is there. Then when we do palpate these patients, they have tenderness, and the tenderness can be isolated along the tibialis posterior, or it can involve the other surrounding joints also. The patient, depending on what stage we are seeing, they can also be having tenderness in the subtalar joints. So too many toes is something which we always see if you are looking at this patient from behind. Normally, we don't see more than 1.5 toes. We generally see only the little toe or probably a little of the fourth toe also. But in these cases, whenever there is a severe valgus or a quite flat foot deformity, you can see that then you may see even 4 or sometimes even the great toe might be visible from behind. A single heel raise test is a very simple test wherein we ask the patient to stand on one leg and just perform a heel raise. We don't allow them to take any support, or if best, allow them only to take a very small support. And if the ability to perform this distinguish whether the patient is having a hind foot which is flexible or a hind foot which is not flexible in those cases. Then we also look at the silver spiral test, which is familiar to all of us, to check whether the tendocellus is tight or if it is a tightness which is coming from the gastrocnemius. And we also look at and palpate for the tenderness in the other joints of the foot. Once we have done this, we can probably zero down to see, and of course, with all the imaging that we do, we can zero down and see where that patient lies. So it's a stage 1. Then there is only pain and swelling over the tibialis posterior tendon. There's a lower flat arch. There's no significant deformity in the hind foot, and there is pain on performing a single heel raise. So this is what we are looking for. And when we do this pathology in these cases is just a tenosynovitis or tendinosis involving the tibialis posterior. And this can very well be managed by just means of conservative measures. We can give them a brace, we can give them an AFO or anything that would rest the hind foot would be sufficient. And once the active stage is through, the patients can probably get back to most of their activities. And only in cases where this conservative treatment is not working is where we should plan for some kind of a debridement or a repair of the tibialis posterior. And if we can identify a tear in these cases, we just proceed with the tubularization of the tendon itself. Now, when we're looking at the next stage now, we are looking at the tibialis posterior tendon, which is a little beyond damaged. So this is something which requires a surgical repair. And when we are doing weight bearing, we also appreciate the fact that the navicular is dropping down, and this is the beginning of a stage 2A. So when this is seen, we have to plan for something more. We can look at it in the stage 2B now. What is happening? The hind foot, which was here, you can see by means of the bone models which are taken, the valgus which can be appreciated. On the right hand side, you can see something which is a flexible flat foot, wherein standing on the toes, the hind foot is aligning itself along the tibia. And on the left-hand side, you are seeing the heel valgus, which is still present. So this, when it is correcting itself, this is a stage 2B, wherein the hind foot is still very flexible and the flat foot is flexible. And we can plan for treatments wherein we're going to go with certain investigations, getting the different views and the way it is taken. And then we're going to go with procedures wherein we can plan only a medial sliding calcaneal osteotomy and something for the tibialis posterior tendon itself. Now, once it is fixed along with the hind foot valgus and a forefoot supination, so then we are going on to a stage 2B. When now this is where what we need is something to do for the supination, to correct supination also. So in that stage, what we are going to do, we are going to go with the correction for that, and for this we are going to do the also cotton osteotomies in these cases. Now this is how the FDL transfer itself is performed. We are going to debride the tendon and the tendon which is of the tibialis posterior, and excise the part which is probably not very functional or is quite degenerate. And then we are going to take the FDL which is just adjacent to it, pull it through the navicular and suture it onto itself. And the other thing that we are also going to do is perform the medial calcaneal slide. In this, what we are doing actually is that we are shifting the mechanical pull of the tibialis of the tendo-Achilles medially, and this is going to bring the heel closer to the tibial shaft, and we are going to achieve a stable hind foot and correct the adult flat foot. And this was what I was telling you. If there is a supination also which is associated, then we have to correct that means of performing a Cotton's osteotomy, wherein we are introducing a graft and correcting the supination by an osteotomy through the medial cuneiform. So, and the position of the wedge itself is going to tell you how we have got this correction there. The silver-scale twist, of course, we all know, and if there's an associated Achilles contracture or gastroc contracture, we can plan the procedures well. We could either go with the strayer or PS, or in the if it is involving both the Achilles itself, then we're going to go with the tendo-Achilles lengthening, probably percutaneous lengthening in all those cases help. Weight-bearing CT scan is a luxury for most of us. However, maybe some people like Pradeep in Mumbai who have the opportunity to use this. And this is what is currently the basis of classifying this into a progressive collapsing foot deformity. So wherein we are able to identify the impingement happening at the anterolateral side. So we have seen the calcaneus which is abutting against the lateral malleolus over here. And this is when these chronic subluxation of the subtalar joint caused all of these rotating of the calcaneus externally and is called as impingement happening over there, subfibular impingement. So this, so in this, what happens is that the medial side, the patient reaches this stage, medial side pain would have decreased and the lateral side pain would start increasing. And this is when we have to plan for something more. The talus is already sagged in these cases, the navicular is moved dorsally, and the spring ligament is attenuating or rupturing. So that's the comonitous sign which I am referring to. The talonavicular is already uncovered. And in these cases, we should think of something like performing a lateral column lengthening. So when this is done, in addition to all the procedures which we had planned earlier, we can also lengthen the lateral column and bring about the impingement from reducing itself. So before this, we have to always check for the flexibility, and only in cases of flexible flat feet is this procedure going to be performed. Now, we also have indications where the heel valgus is also, in addition, we also have the medial column which is unstable. So in these cases, we have to plan for a stabilization of the medial column completely, and then we have to go ahead with the arthrodesis. So this is what we need to do. We need to go with the medial column arthrodesis depending on which are the joints involved, and then perform whatever is required on the lateral side with regard to the length of the calcaneus itself. Now, this is the current concept which is being spoken of, and this has been announced in the 2020 that all these days what we have used to classify as an adult acquired flat foot is probably a lot more than what we were thinking. It's not only the tibialis posterior. There are multiple causes which are causing it, and so with that the only two things can come out of this. So either the foot is flexible or it is rigid. And if it is flexible, then we can have then there are different classes which are assigned to it. You have a class A wherein there's a hindfoot valgus deformity, a class B where there's a midfoot or a forefoot abduction, a class 3 where it is forefoot varus. So this is very similar to the type 2C which I have told you about. And in the class D where there's peripteral subluxation or dislocation, which is a class stage 2D, the treatment which I just mentioned to that. And in class E, there is going to be an ankle instability. So we could have patients who are in a combination of these. So you could have a patient who's having flexible hindfoot valgus, but would probably have a rigid midfoot or have a rigid or a fixed class C. So in those cases, then we can classify this as the patient who has a 1AC with a 2D or something of that sort. So that's how we are able to arrive at the treatments for these patients also. So the surgical procedure selection is always based on that. And sometimes we can even use diagnostic injections by injecting some local anesthetic to find out what exactly is causing the pain. Just a couple of cases which I thought I would just show here. This is how a lateral column, how a medial calcaneal sliding osteotomy is performed. So that's the incision to be taken, taking care not to damage the sural nerve. And this is on the medial side. We're going to expose the tibialis posterior over here using the utility mid-medial incision. So, and this person also had got a varus deformity of the great toe. And this was a flexible deformity. So I went ahead and planned for the hindfoot valgus correction by means of a medial calcaneal sliding osteotomy. That's how the osteotomy is performed, and it can be fixed by means of 2 CC screws, which stop short of the subtalar joint itself. So we would need very small length screws in these cases. So once that is held, you can see the amount of displacement that we are able to achieve. We always take the axial view to see how much of displacement is achieved, and we can fix it with screws in this fashion. So you can appreciate the amount of displacement which is there. We can displace up to a centimeter, and now there are plates which are available. I have used these plates also, but I don't have them here in these pictures. We can use plates where a fixed amount of the medial calcaneal slide can be performed. And then, of course, we have to address the medial side, identify the tibialis posterior. You can excise what is there, get that the FDL tendon from there, create a tunnel in the navicular and suture it back onto itself, or use newer toys which are available, which come from different companies. So then for the soft tissues for this virus, I corrected by just performing a tendon transplant, holding it down by means of a K-line. Another lady who had a fixed forefoot hallux varus, so, and had a degenerate joint in this case, so wherein I had to plan, in addition to correcting the flat foot by means of a calcaneal sliding osteotomy, I had to perform something for the forefoot. So that is the calcaneal sliding osteotomy was there, and the MTP joint had to go for fusion because this was completely degenerate, and these were the loose bodies which are found in the MTP joint for sure. An MTP fusion performed, and the second toe was also addressed in that case. And that's the conclusion that we get because we are correcting a varus deformity. The medial side structures get tightened up and closure becomes a little difficult, but then we are able to achieve what we set out to. The positions are verified, and you can see the difference that it had made with regard to the MTP fusion, the correction of the varus, and also with regard to the hindfoot valgus by a simple, powerful procedure like the medial calcaneal sliding osteotomy. So these are the things, and in case this is very, very progressive, if we are in the final stages that we are seeing this patient, we could plan for arthrodesis, which is involving the joints which are completely athletic, or we can probably have to plan for adjunctive procedures. And in case of a very final stages, we might have to end up performing ankle fusions or even TTC fusions in these patients. And if it is a stage 4 with only a deltoid incompetence, we would have to address that by means of performing a deltoid reconstruction also, in addition to the flat foot reconstruction. So these are the selection of treatment. So just short, summing up everything, it's a very huge topic, just kind of to highlight on what all is possible, what all can be done in these patients. With proper clinical history, proper neurological assessment, vascular assessment, assessing for gastrointestinal tightness, looking at the skin condition, and all of these help to select the treatment modality for this patient. And more above all, we have to match the patient's expectations. If it is only pain relief that you are looking at, or a correction of the hand of the flat foot ones. Thank you all so much.
Thank you very much, sir. So are there some very relevant questions? We can take a couple of them.
So when we are going for calcaneal displacement osteotomy, how we is there any method to calculate how much displacement it should be there?
Yes, so that would ideally be taken by means of the Salzman view. So once we take the Salzman view, we can identify how much of the hind foot has gone into the valgus. So we can measure that. We can take the tibiocalcaneal angle. So we can use that, and once with that we can decide on how much of a shift we require to align the calcaneus underneath the tibia.
Sir, I have two questions. First one is while correcting, after correcting the deformity, often we see that the skin over the lateral incision gets tight. So any tips and trick to avoid that? It is often difficult to close. Sometimes I have experienced this. And
yes. Yeah, no, that's what. So these are no known facts. So if you're planning for a column length for a medial calcaneal sliding osteotomy, then the closures generally won't be much of a problem. But if you're planning for an arthrodesis, subtalar arthrodesis for a valgus deformity, if you're doing from the lateral side, you will have a problem. So in those cases, what you can do is going with a fusion from the medial side. This is a procedure very classically described by Professor Hinterman, wherein we can do a medial incision subtalar fusion or a medial incision double orthodesis. So that way you can avoid the skin complications.
So,
Kamal want to say something.
replying to Dr. Meena, you said in your medial calcaneal slide osteotomy, you have a problem of closure of the skin.
No, in cases of arthrodesis, sir.
Only in cases of arthrodesis, the lateral wound or the medial
wound?
Lateral wound.
Yeah, just
so you know when there is a long-standing valgus, the skin on the lateral side would contract.
Yes.
So if the longer the valgus deformity is, longer the planovalgus foot is, your medial skin is expanding, your lateral skin is contracting. Do them from the medial approach. Don't do them from the lateral approach.
Yes.
That's the way out.
And how often do you lengthen the peroneum in cases where the peroneum is also long-standing and it is tight?
I never had to do it.
Peroneus generally is not required because it's a soft structure and generally corrects itself, so we don't have to.
Moreover, when you are fusing the subtalar, you are not, you're not wanting peronei to do the eversion. You are fusing the subtalar joint.
Okay, sir.
Any other question from the panelists and faculty?
I think Joy has otherwise very beautifully enumerated the whole of the adult flat foot, different stages and how to manage them. That's been a beautiful presentation by all the speakers. And I think the Uttaranchal people have become, half foot surgeons by attending this webinar.
Yeah, definitely, sir.
So Ganesh, I think we should conclude now.
Yeah, yes, sir. So it was a real academic feast today. Sir, I want to thank Indian Foot Ankle Society President Dr. Simon sir to accept the invitation at the short interval. And I thank all the four speakers who are acclaimed foot ankle surgeons. And they are spearheading the IFAS community to newer heights. And the topics were very, very pertinent. And I think the learning from that topic should enrich the knowledge of viewers. And some change in practice is expected. And I also want to make it a point here that Indian Foot Ankle Society has, I want to congratulate them. They have dedicated the month of November as a whole week on on a particular theme for the educational purposes, awareness purposes. And that would go a long way in the future to better make public aware of various foot ankle issues. So with that note, sir, I really thank everyone, all the panelists, Dr. Puneet Agrawal, sir, Dr. Puneet Gupta, our president, and Dr. Badoni, Dr. Pradeep Pande, Dr. Meena from Uttarakhand, and the OrthoTV team, which are becoming a Netflix of orthopedic content. So I'll thank you all of you. Thank you very much.
Thank you, everybody.
Thank you, Rajesh sir. Thank you, Kamal sir. Thank you, Ajoy sir.
Thank you.
Thank you,
Thank you
Philip
so
sir.
much. Thank you.
Good night, sir.
Thank you very much for having us.
Thank you.
Hey, it's in the car now. Okay.
Thank you, sir. Please. Good night, sir.
Thank you, Poonam.